Yes, sure. So there are many advances in the past decade. The most obvious and important was the development of curative therapies for hepatitis C using oral medications. This has been the most transformative development in treatment of liver disease in many years and is slowly but surely curing most patients with hepatitis C, both in the United States and throughout the world. So this discovery of new treatments really was a direct consequence of the Nobel Prize winning work that was recognized by this year's Nobel Prize for the discovery of the hepatitis C agent, and the recognition of Michael Hounton, Charles Rice, and Harvey Alter. So now we have curative therapies for hepatitis C, and the major responsibility for healthcare providers is to screen for hepatitis C, to identify the disease so that we may cure all patients around the globe. The consequence of that is that already, and even more in the next few years, we will see a diminishing number of patients with advanced hepatitis C cirrhosis or hepatocellular carcinoma. So this is a extraordinary success story for basic research, but also for drug development and for public health. That's the most dramatic improvement. But in addition, we are harnessing the power of newer molecular techniques to both discover new diseases and to classify those diseases that we had already understood. So for example, genetic studies are now uncovering the basis for a large and growing number of disorders of biliary development and bile duct development that are leading to greater understanding of classifications for congenital liver disease. At the same time, there's dramatic efforts or improvements in our understanding of non-alcoholic fatty liver disease, and in particular, the discovery of many key pathways that are driving the disease and that are representing potential therapeutic targets. At the same time, there's been a huge investment in developing new technologies to diagnose liver disease, both in patients with suspected non-alcoholic fatty liver disease, but also for other disorders, in order to both diagnose and stage liver disease. For NAFLD and NASH, that is a critically important need because currently clinical trials rely on liver biopsy. However, this limits our ability to conduct clinical trials. And so there are progressive developments in the application of non-invasive methods of liver disease diagnosis that will slowly but steadily replace the need for biopsy in the next few years. At the same time, more treatments are available, both for, as I mentioned, hepatitis C, but there are increasing numbers of drugs being tested for non-alcoholic fatty liver disease. None have been approved yet by the FDA, but those of us in the field are very confident that these new agents will progressively become established as potential new therapies for non-alcoholic fatty liver disease. And so both basic, translational, and clinical efforts in research are steadily advancing the prospects for good health in patients with liver disease. Personalized medicine is slowly developing progress for many kinds of liver disease. The most important application is the discovery of causes for unknown liver disease. There have been a few publications that identify novel causes of liver disease in patients who lack a diagnosis. So more broadly, genetic technologies like whole exome or whole genome sequencing are discovering previously unknown causes and defects underlying liver disease. But in addition, these techniques are being used increasingly to subdivide or subclassify forms of liver disease, both diseases in children that are congenital, but also in non-alcoholic fatty liver disease and NASH. We are discovering a growing list of genetic variants that increase or decrease the risk of fatty liver disease. Those are not currently being used clinically yet for managing patients, but I believe that over time they will emerge into a clinical risk score that will both define the underlying drivers of liver disease and perhaps refine the choice of therapies based on the genetic composition or drivers of the disease. We should also remember that the concept of personalized medicine extends not just to the genome, but also to the epigenome, as well as to the microbiome or the metagenome. And there are very exciting studies that indicate that the composition of the microbiome may be an important determinant of both the onset and severity of liver disease. We are at very early stages in understanding the microbiome, but I believe that over time, understanding the genetic and secretory phenotypes of gut bacteria will lead us to uncover novel pathways of disease causality and potentially novel therapeutic targets. And so as we advance all of these technologies around personalized medicine, we will steadily refine our ability to both diagnose, classify, as well as treat different forms of liver disease. Still many challenges. One is that the technologies to interrogate tissue and genomes are not evenly distributed and available throughout the world. There are major centers that have the capacity to do genetic analysis, but it's not available widely in clinical practice. And so the first challenge will be to broaden the availability of the infrastructure necessary to use personalized medicine to influence patient management and treatment. The second obstacle or challenge is education. Not every clinician understand. In fact, very few clinicians will understand the genetic basis for many of these diseases. And so as we begin to integrate genetic information into a patient profile, we need to educate the providers so they understand what the information means and how to act upon it. Related to that, we need improved software and computer-based solutions that can seamlessly integrate genetic information not only into the patient record, but can also provide treatment advice to the providers because busy clinicians will not have the time to interpret genetic analyses, and they will need the assistance of specialized software that evaluates and integrates genetic information into clinical treatment recommendations for screening, for management, and also genetic counseling for family members who may have liver disease. So we have many challenges ahead, but the technologies are there. And as we learn more and reduce the cost of these technologies, we will be able to integrate them into clinical management.